It's an honor to be over here, especially for Dr. S.K. Shah sir. And I knew Chandrika madam. She was like a mother to all of us. I last met her in the National Conference 2021. And at the outset, I like to thank the organizing team of Navsari and GSB team to give me this honor to be over here. When they told me that I'm supposed to deliver the talk, so it was very difficult for me to select the subject because I never wanted anybody to get bored. So I just looked at the theme of the conference, that bridging the gap, theory and practice. So being an academic institute, I just thought that I should do something about the academics too, and when they have to apply practice, how they should be. So, anesthesia, privilege of medicine, idealistic versus realistic. People who know me, they always say that you are expecting too much. So I think this was the topic. I think I can do well. So when we are in 12th standard and we have to select something, we all have high hopes to become a doctor. And the main thing what we have in our mind is, you get a good salary, you get good respect, gratitude, job security, you can travel as and when you want, and there is a career satisfaction that you are a doctor and people treat you as a god. Now after MBBS, why to select anesthesia subject? When people come over there as an intern, I definitely take lecture for this particular thing, that why you should go for anesthesia. And somebody, when I was to select a branch in 1985-86, somebody told me, he was a surgeon, and he told me that why you should select anesthesia. That is, one is, how many branches take admission with you? Minimum 5 to 6 surgical branches, surgical specialty. Now you have the surgical super specialties also. So you will get a job easily. You will never die youngly if you do right practice, and you will not have to invest anything. So that really struck my mind, and I left PNT, ophthalm, everything, and I joined anesthesia. And you can see this slide that doctors were identified in 1945 and anesthesia was invented in 1846. So it was only 1 year's difference. Now in the lower slide, we know our Dr. Ganesh Chaudhary. So we know how to evaluate it. The last one you can see is mobile app anesthesia person. So this is what we have progressed. We had minimum mandatory monitoring when we were students, and our seniors used to always tell us that you should have the eyes behind also, to keep the watch over the trolley, because there no monitoring was there, and the pulse was the factor that you have to go ahead with the BP and everything. You are meant to be on pulse. So these were the things we have evaluated. Now, why I say it is a privilege of medicine? It is rare, means infrequent, not seen very often. Privilege means there is a Visheshadhikar, special advantage or right possessed by individual or group. Combining these two, something that is uncommon and therefore it is interesting and valuable. Why I say this? Because each and every patient is going to teach you something different. Not a same patient is going to come back again. The last one, when we join anesthesia, we are fascinated always that it is sitting in a chair. You are just going to silently judge everything, how the surgeon is working. At the last, you can have a cup of coffee in between if you want. So this is the triad of anesthesia. But when you actually join, you get only a time to get a cup of coffee, very fast to sip on, because there is a patient involved. There is a general opinion. When anesthesia is administered, you find out the secrets of the person, and that is what they do in the narcotics. But it is nothing like that. We always kept the secrets within us, what is there happening in the operating room. It is for surgeons, patient and anesthesia, all the people. And there is another saying that we are always a physician with the nerves of steel. We are very solid people. We are the captain of the ship whenever there is a surgery on. Earlier in the days, we were working behind the curtains, and surgeons used to say, "Come on, please adjust the light for us." Up to that extent, that there were jokes also that if a surgeon was traveling in a plane and he wanted to adjust the light, he said, "Call us the anesthesia person." No more are the days with this current era. We are out of the curtain, everybody knows us very well, what we are doing and what is our role in the society. So you see the three figure on the side that says that there is always a bloody surgeon on the other side of the curtain. Now the idealism and realism. Ideally, what we see, something that is hopeful manner, shaping the situation with your own ideas, that I want to do like this. They are very positive and they perceive things and carry out the task very easily. The decision making may have lofty ambition that I want to do this, but lack of clarity and focus to put them into action in an achievable way. That this decision is very risky, and because it is based completely on the theory. Theory is something which might not be actually we are able to do in the practice. So, realism causes one to access a situation. It is without overt emotion involvement. It is less positively done. Decision making realists are goal-oriented and thorough, sets achievable goals and follow the pursuits in a planned manner and make safer and more practical choices and they work with the facts. You see a very good anesthesia person sitting over there, watching up all the things and everything with lots of gadgets on over here on the right side. So this is what is happening in today's era. We are losing our human contact and human touch with the patient. There is a general opinion, a significant, sustained and embedded contribution to the promotion of the diversity, equity and inclusion in the workplace. And who does that? Outstanding competition, all the areas of anesthetic practice, clinical excellence, teaching, training and supporting colleagues. The only one person does is the anesthesia person. Idealistic anesthetists, personalized care plans, optimal depth of anesthesia, perfect pain management and minimal side effects. It focuses to provide the best possible patient outcome, priority to patient safety, patient comfort and individual care with a tender love. The reality is something different. It is persistent challenge that may compromise idealistic goals of anesthesia. Because of time constraint, limited resources, maybe staff or equipment, complex patient comorbidities, economic pressure and variability in the patient response. One has to bridge the gap. So we reconcile idealism and reality. Evidence-based practice is more than adaptation of the situation, advocate resources and support quality care by policy changes. We can change according to the condition where we are working. We adapt it very easily. Now there is always a debate, but what we work with is optimal patient care and navigating the practical constraints of the critical delivery. Patient safety is a priority. Now coming to the education system, because there is a theory there. So it is always fight between old versus new. The medical council was there from 1933 to 2020. The NFC was started in September 2020. Now what is the difference in the functioning between two? NFC has set the goals. It started from the ambiguous field. And what they want is there should be explanation of the administration of the anesthesia, management of acute and chronic pain, maintain airway, they should know how to do it, explain principles of oxygen therapy, perform pulmonary resuscitation and the consent importance of it. It is more learner-centric, patient-centric, gender-sensitive, outcome-oriented and environment-appropriate. They emphasize more on the horizontal and vertical integration of the subjects. We come to this and it is mainly to develop good competencies. Now they give something like this to all the teachers in anesthesia and it is very difficult to understand this and you have to go to the depth of it. So mainly what it is knowledge, skill, attitude and communication and there is something called DOPE, that is demonstrate, observe, assist and perform. So coming to the anesthesia training, it is mainly this knowledge, skill, attitude, communication. Between this, there is one addition H, that is how they do it. That comes in anesthesia. That is, and there are different levels of competencies. This is for MBBS, so we are no more behind the curtains from the day the doctor takes admission in the first MBBS. There are different goals that are set for us and we have to do that. I will not go into the depth of it. Now, when we encounter the first, that is the foundation course, we teach them the basic life skill. So our first encounter starts from the foundation course and they know that we are existing over here. Now, as Adrian says, who was the secretary of the PFSA, anesthesia is the bridge between suffering and relief, between disease and cure, between fear and hope, and it is a vital component of modern medicine that enables millions of lives to be saved and improved every year. Like students' modules, there are teachers' modules also. So, how the teachers are going to be trained? There is medical education training of teachers' programs that every teacher has to go through. At-home competences, ethical values, responsiveness to the need of the patient, and acquisition to the communication skill. This is very important part of the anesthesia practice, that you have to explain to your patient what you are going to do and how you are going to work with it. So there are no malaprati in the operation theatre or in the emergency room. The great emphasis is on the teamwork. Interdisciplinary teamwork is very important when we work in anesthesia, and professional relationship with the other team. Now, what the PG teachers' challenges are faced in today's era is, there are always administrative issues. We academicians are not very good administrators. Then there has to be mandatory rotations we have to manage up, which was not there initially. Teaching as per the NMC, because they say that 6 months for the surgery, we have to give 6 months for the surgery. Then along with all these things, long working hours, and there is a list to be completed in many of the hospitals. So when there is a quantity, the quality suffers. There are additional duties of VVIPs, infrastructure is lacking, teaching resources and manpower is again lacking, and there is a time constraint always from 9 to 5. You might have to work long hours. It is mainly student-oriented NMC nowadays, what we all teachers say. They say that there has to be 8 hours fixed for the residents. When we were working, there were no working hours limitations. It was a big hurdle during our era. In current era, it is nothing specific. You can directly submit at the time of the exam also. There is changing exam pattern now. It started in 2020, so they also keep on changing the NMC protocols. Mandatory lectures introduced during the admission. Along with all these things, webinars, they say you have to do it. So all the colleges are bombarding with the webinars. You have to do it online. Then life-saving skill certification. Recently they will produce all the anesthesia people, not every student who is in a residency, all the subjects, they have to be BCLS trained. So again, that's an additional burden. We don't know, they don't want to pay, but they want the certification, which is very difficult for us. Then there is a BCBR exam, that is, you have to go through the student and teacher, both go through the exams. It is very difficult at certain age to read those kinds of statistics and appear for the exam online. Anyway, then there is a burden on presentations. Like today, we had lots of presentations. So teacher has to work for everything, they have to get the things done. And like other branches, we do not have students with us. They are rotating. So it is very difficult to cope up with all these burdens. But teachers' stress, nobody sees. Again, I say, it is simulation-based training era, but we have lack of infrastructure. Then action. During our era, madams and sir used to give us some punishment. But in this era, you cannot. They can directly report to NMC, you have to face the legal action. So in this current era, the PG teacher is afraid of the student rather than the student getting afraid of the PG teacher. Then you have to compromise with the quality when the quantity is more. The government is always asking us that you increase the seat as per the needs. Let me tell you, I increased the seat in BJMC from 40 to 52. But when I see the quality of work, I repent that I should have not done that. The quality is going down when the quantity is more, but we have more number of operation tables, so we have to ask for it. Compromise work should not be appreciated. Super speciality subject teaching is again getting popular. So government is forcing all the teachers and government colleges that you start this course, this course, this course. But we are lacking too much infrastructure. The lack of interest in the institutional lectures, because we are getting everything ready to go in different forms online, and during our era we used to visit libraries sometimes. Nowadays no student has it in the library card because everything is ready to go on mobile. Now there is something that introduces district residency program. Even they are in problem and we are in problem. We have to reschedule the rotations as per NMC. They work in district hospitals for 3 months. And they just lose the contact with the PG teacher and the institution for 3 months. So again when they come back, we have to go for the 0 day. Changing era, the attitude of the residents and staff members are changing. Student-teacher relationship is totally different than what we had. Discipline, protocols, honesty, you have to question mark sometimes. Logbook maintenance, again it's a burden on the teacher and the student both. There is again something that will introduce SRship is mandatory when you become the assistant professor, when you want to become a teacher. So SRs, there are no protocols to work, there are no rules and regulations that governs them. So for an administrator at the institution, you find lots of difficulties. Now test textbook versus question banks. We used to do textbook and we used to get the question answer after reading the textbook. Now students only read the question answer book. They do not know what is something called textbook. When you go in the operation theatre, there is a hierarchy. Where do you stand? It is surgeon first and first assistant. That is anesthesia person. Now there is something called PMJY Yojana, government people must be knowing. They were distributing the money. Surgeon was getting highest. We were paid 2% less than nurse also. So all the anesthesia department people refused for it. So that is what the government made us, but we stood up all together and we got more than that. Now it is students' pride and teachers, and why I say that? When they get this strike, their pay increase. If their pay is more than our assistant professor's pay. So this is why I have written down this sentence. Now teachers also have to set their standards and qualities. They have to undergo different trainings, but there is no government-sponsored trainings for them. They have to find out their own. They have to improve abilities with the current era of training and certifications. Then teaching experience versus real teaching. It is just a question mark and justifications are needed. All the teachers cannot be good teachers. It is really very difficult to be a good teacher to go down to the students' level of expectation. Then there are different programs coming up, is DNB and BDA, CPS training programs. Again, that is a competitive with our MD degrees. So we have to stand all together to stop these training programs and get the MD only or DNB. There can be introduction of nurse anesthetists. There can again get the competition with our students who will go with the practice. Then nurse anesthesia assistants. So assistant again, they are degree holders and trained people, but they are going to help us. They cannot do the private practice. Here I like to comment that government started something for the obstetric LMO training, my MBBS level training. What they are doing is they are not practicing at the hospital. They are doing the private practice, and that is not wise decision. The government doesn't take this into consideration, and the patients are at the risk. Current programs include the collaborative residence teaching, self-teaching, group training, program-based learning. That is what normally we are doing at the operation site. Educational integrated package, simulated case scenarios, teleeducation is something that is there, and artificial intelligence. I think Dr. Kushar is going to talk about that. There was one beautiful study I came across in that this was students' expectation from the teacher, what they will like to be with the teacher. They will like to be maximum bossy authority. They want to have their own authority rather than the teacher having the authority. The second one was they want to have a teacher who is little different. The rest were, you know. Then there were essential values in the anesthesia as what they expected, what the teachers expected. You can see the graph itself, the responsibility is down, it goes up to the empathy. So this is what we have to work at the grassroots level as teachers to make them good practitioners when they go in the practice. Good teacher has to have a dedication, positive attitude, high expectation, and needs to update at interval and greater extent motivated. There are other desirable principal values, but I will not know the details of it. Teaching of anesthesiology that requires a comprehensive reform that gives the same weight to techno-scientific knowledge as to the development of the emotional, social, and spiritual spheres of the participating actors. Good teacher. I like this sentence. Never underestimate someone who knocks people out for the lead. That's what exactly the anesthesia people do when we administer general anesthesia. So we need to have collective effort to achieve the comprehensive training of human persons with desires and needs who are capable of providing safe and quality care, experiencing satisfaction and personal fulfillment. Here you see lots of qualities over here, and one of them is spy. We don't spy surgeons, we don't spy anybody, but for our safety we should know what is happening. The other side are written. It is a science of preventing a surgeon from cleaning his or her patient. Definitely we are doing that. If they are wrong somewhere, we just point out that this is the thing you need to stop. There are lots of documentation issues nowadays. We are not working at par with the US and UK, but still documentation is very important in our branch, and one has to have all these things. There can be burnout syndrome because of long working hours and lots of things to be filled up, lots of form. All the hospital wants to have NABH accreditation. NABH accreditation, it is only the forms and forms and forms to be filled up. And that is the reality. It is not the what we are exactly working. We are writing something on paper and we are doing something in reality. There has to be satisfaction with the work-life balance in the life of an anesthetist. A wisdom of anesthesia is there is always a hours of boredom, but there is minutes of thrill. The adrenaline secret thrill of it. वो खराब patient होते हैं. With all these things, amongst the residents, they cannot take the stress of anesthesia and they got under depression, and there are many cases of suicide, and which we need to prevent. And teachers are the best people who can stop something from the beginning. All the people of my seniors and my era people know this figure very well. We were supposed to have 10 hands and 3 heads and scats and everything. Nowadays it is not required because we have got excellent infrastructure. We used to follow many rules and regulations that once you enter the theatre you have to do this, but nowadays all the equipments are very well updated and you just need 5 minutes to go through, prepare the trolley and machines. It was a joke that anesthesia is ABC, that is airway, breakfast, coffee. It is no more like that. There is a lifelong learners with values. This was written in 2017 by Robert Chia, and they said there is importance of a fiduciary bond. We have to our patients. The importance of our observing ethical principles, the immense responsibility of teaching the future generations of physicians, and the importance of excelling at what we do by being lifelong learners. There are immutable and there are values of medicine that is to be carried out for the future generations. There is immutable, mutable. There are many things which we need to carry forward to our newer generation for the patient safety. This was written in 1950 by Harrison, what we read in medicine. No greater opportunity or obligation can fall the lot of human being than to be a physician. We are perioperative physicians to be anesthesiologists. In the care of suffering, he needs technical skill, scientific knowledge, and human understanding. He who uses this with courage, humility, and wisdom will prove a unique service to his fellow man and will build an enduring edifice of character within himself. The physician should ask of his destiny no more than this, and he should be content with no less. So this is what we all anesthesia people are doing in day-to-day basis. Now, what should be the action plan for the balance? There has to be evidence-based practice, personal care, monitoring, we should not compromise. There has to be team effort, surgeon is a part of our team, and there should be advocacy when the research and enhancement policies are there. There has to be reality checks, resource constraints, there are limited availability of many things, but we do not compromise the quality of care. Time pressure is always going to be there, and whether you work in private or you work in the institution. You have one call and you have to rush for the another call. You might compromise somewhere. Then there is always going to be patient complexity, but we need to adapt rare presentations and rare disease associated with communities, and we have to work for the basic economic factor. Yesterday there was a very good seminar on the financial background and how anesthetists can make good money. So that was a good thing, and one has to not compromise with the prices. Nasik is a good model for the private practitioners that everybody sets this amount only for this crop. There should not be any compromise to stand up for our branch. Human factors. We are the best judgment is affected by fatigue, stress, and cognitive biases. So we should not compromise with this, and we should not overwork. We have to plan for the future for the opioid crisis, so we have to come for the new techniques. Staff shortage, we have to ask for it or stop working at the institution level. Equipment limitations, if it is outdated, do not use it. Stand up for yourself and say no for it. Electronic health records, I just say it is a burden, additional one. And infection control, you have to watch for your safety too. Then solutions. There are lots of new innovations. We have to work for that. Research and development, we have to go for the newer technique, drugs and protocols. Training improvement has to be there. For that, the simulation is going to be there at all the colleges. Then patient engagement. We have to involve ourselves with the surgeons. If we are working in ICU, we have to be with the intensivists to take the decisions why we are doing this and we are doing this. Then we have to go for the global health initiatives too. Regional anesthesia, we have to go for the many new techniques, and day to day we are doing this. Then we have to reserve anesthesia effects for the first week in the ADAS protocol. Then there is something tele-anesthesia. We are doing PCPR also. Then artificial intelligence is going to be there in detail. Focus, we know how to put the needle and where to put the needle. In future, there can be robot-assisted anesthesia. But to comment over here in a short way, that nobody can replace you. Robot doesn't have brain. It has a chip in that. Then there has to be virtual reality. One day one MR came for the virtual reality. He was just doing like this with the 3D glasses. And believe me, you can learn all the anatomy, you can learn everything how you have to do it. And that will be the real good era without training them on the real human beings. 3D printing, again it is the same way. PCPR I have already taught. Then there is wearable devices for the vital sign monitoring. Here I would like to comment one thing, that how much database standard is deteriorated during the COVID era. I have shared this with many people. When I took the lecture, I first asked how many vital signs are there. So we learned 4 vital signs. Then came the 5th vital sign P. But they told me there are 7 vital signs. I was surprised. How come I missed? Then they say urine output is a vital sign. I said, why urine output is a vital sign? They explained to me there is a cardiac output, the kidney will function. I could not say no for it. But again then he said, the height and weight is also a vital sign. I said, all the height and weight matters. Then he showed me the Google one. I said, you'll be a good Google doctor for your Google patients. So that is the standard has gone down to MBBS level, but we need to improve when they come to us, and we really need to work hard for it. Then for the anesthesia information records and all, we have all the data analysis things and cloud-based anesthesia storage. Then patient outcome has to be improved and enhanced, and complications has to be reduced whether we work with idealistic or realistic. And we have to increase our efficiency, personal care for everything, documentation when you are working in private, and there has to be cost-effective solutions to reduce the resources utilization. I've already talked about this strategies implementation. Then when somebody takes admission, one has to think that, can I do this? Then only can do anesthesia. Am I a problem solver and critical thinking person? Excellent communication and interpersonal skills, attention to detail and focus on patient safety, ability to work well under pressure and in a high-stress environment, strong knowledge of anatomy, physiology and pharmacology. We cannot afford to forget that. There is a limitation and challenge, that is data quality, algorithm bias and validation can be there, which will be done by AI, clinician acceptance and training, regulatory framework works. Cyber security is going to be one of the important parts of this. Pain management again is going to be AI assisted, and expansion of the extreme ages pediatric and geriatric anesthesia. Robotic anesthesia. Somebody might think that all these anesthesia people are gaming in the gaming zone, but no, they are doing the robotic anesthesia. And that one is the last one, is the bright practitioner running around with lots of equipments because he has to improve somewhere. But instead of doing this, we can tell our surgeons to go ahead with this. One thing I like to comment over here is a woman leadership in anesthesia. Still, there is gender disparity at the higher level of leadership and academic anesthesia. There are some indications that women may be on the path to leadership parity, most notably the growth of women in anesthesiology, residencies and faculty positions, and increase in this in research grant awards to women. There has to be patient privilege. It's a legal concept related to medical confidentiality, and that protects the communications between patient and the doctor from being used against the patient in the court. That is what I commented, that if we are good communicator and we explain our patient is never going to go against us in the court or no. Believe me, take your patient into confidence first rather than running around with the surgeons to save your skin. Medical, legal and ethical issues in anesthesiology profession is very common nowadays. This was written 1880, that is Varva Volant Scriptum, meaning spoken words fly away, written words remain. Your documentation will save you from any upcoming issues, and documentation is one thing. Again I say, consent is another thing that is going to save you from all the little hassles, whether you are in the hospital environment or you are in the academic institution. We were the leaders and we set the role models during the COVID era. Everybody agrees with that. Coming to the very important aspect, salary. In abroad countries, anesthesia people, you can read by yourself how much they are making money. They are number one, it is very difficult to get into anesthesia. Even the nurse anesthetists, they earn more than all of us in per year. What is the lowest pay? That also is much more than us. Coming to the India, an institute person gets a fixed salary with a ceiling, not more than 4 lakhs. The GMERS people, they are giving up to 5 lakhs. But when you get the pay, it is much less. The bright practitioners, it depends upon the institute they are working, the working experience and everything. but still we are underpaid. Now this slide is interesting. Are anesthesiologists legitimate surgeons? Yes, I think Dr. Gajay, Dr. Sharma and all proved yesterday that if we invest our money, we can earn still more than the surgeons. But it is the way you invest your money. We have great career options, as I say, nowadays we can fit in any category. But we have more burden of teaching them. This was a good editorial. The complete issue was on how anesthesia person can go ahead in the career options and life after post-graduation and anesthesia in search of passion. And limited exposure to the subject of anesthesiology failed to ignite interest, attitude and passion for the subject. It is no more the days we are given exposure from the first primary course of MBBS to teach them basic life support. So the subject of anesthesiology is both dark and brighter sides, which forms the yin and the yang. The yin is, we do not spend much time with the patient. Work for anesthesiologists includes the boredom and moment of terrors. Stress is always going to be there, whether it is a working environmental stress or anything. Then challenging situations are never going to stop quickly. But between all these things, you have to maintain the balance between professional and family life. The yang is, good demand for anesthesiologists is still existing in the country. Despite availability of anesthesiologists and the shortage of qualified one, especially in the rural areas, so we should work for something. The IOC should take some initiative. People are now deputing the DRP posting of resident doctors. Like that, they can do SR's posting also. Delivering anesthesia services, we should perform multiple duties, healthcare management and hospital administration. Working and practicing anesthesia with robots with advanced assistance from nanotechnology, tele anesthesia for tele anesthesia assessment, smartphones and genomic mapping. We should have to optimize ourselves. We are the watchful guardians, as it is said by Jenny Manning. She is the president of WPC. Anesthesia is the art of balancing pain and awareness, risk and benefits, science and compassion. It is a privilege to be an anesthesiologist and to serve humanity this way. Our future. This slide interests me always. My husband is here, he made me see this movie, $1 Million Baby. And there was a topic in ISA 2021, oxygen therapy and anesthesiologists. $1 Million Babies. I'll say why it isn't. That's a Clint Eastwood. He was the mentor for this lady, Helen. She wanted to become a boxer and nobody was ready to teach her. So he takes the responsibility and she becomes the one and she wins the fights. And that's how the $1 Million Baby came into existence. This is a beautiful movie. So when we think of our anesthesia practice, starting from the day joining in anesthesia department, till we end our practice, we are always fighting for one or the other issue. So we are always $1 Million Babies. And to end up this talk, it is a beautiful thing when career and passion come together. Successful careers do not happen. You create them. And we all can create ourselves. I thank you all for your wishes and blessings. I thank my mother who taught me. My husband is my backbone. He's always there.